cough. Because to cough, you obviously have to breathe in as deep as possible first to fill the lungs with air and get air behind mucus. If you have poor airway clearance, of course, that puts you at risk of having lower respiratory tract illness. You can have, come on in. You can start with a cold and then end up having something that migrates into the lungs. And then if you have an acute illness, a pneumonia, or whatever the illness is, that can cause further fatigue, further weakness, and then the debris that ends up in the airways adds load on the respiratory system. And then if you bring in the chest wall, in many neuromuscular conditions, patients will start with a very weak or flaccid chest wall. And then as the chest wall stops moving normally, where the ribs join the spine, that's a joint. And you can get ankylosis or stiffness of any joint if it's not being used fully. And so you can go from having a flaccid chest wall to a very stiff chest wall that doesn't move very much, which then adds further to the burden of breathing and can cause you to have low lung volumes or not be able to breathe in deeply enough to do a good forced exhalation. And then finally, the spine helps to keep you erect, and the spine and the chest wall together provide the space for respiration. And if you have a weakness in the spine or the chest wall, you can end up getting scoliosis or kyphosis, or a combination. Kyphosis is tipping forward, and scoliosis is a right to left curve. And then if you have kyphoscoliosis and a stiff chest wall, that causes you to have low lung volumes. Low lung volumes cause the lung to not be fully inflated. That causes the airways to be smaller, and smaller airways are harder to breathe through, which creates further load. Then ultimately, what determines whether you have respiratory failure is whether the diaphragm is able to overcome the load on it. And so there are a number of ways that we have to help lessen the burden on the diaphragm by improving the load or the work of breathing. And so we'll talk some about that. Let's start by talking about managing respiratory difficulty. And I'd like to break this into 4 components. The first is what you guys all do, which is recognizing the onset of a respiratory illness. Then the next thing is optimizing the timing of intervention, whether it's something at home or coming in for an acute care visit, and then having strategies that have been developed for the patient that are effective, and then recognizing when you need to seek acute care, seek additional help, because while you may be the best caregiver for yourself or your child or your patient, there's a limit to what you'll be able to do long term. And so recognizing that limitation is also very important. So, in recognizing a respiratory illness, the single most important thing is having a caregiver recognizing a change from normal. And what I tell the parents of my patients is that if something doesn't look right, that's important. I don't really care whether you can say the aeration in the left lung is lower than the right lung, or there are crackles, or I'm feeling something. If your child's not doing isn't behaving the way that they typically are, and it could be they're just as ornery, I don't know what's going on, something's bothering him, that's important. And then reaching out to the medical team to help tease out what might be going on would be an important next step. So signs, just general signs of a respiratory illness. Of course, you worry about it if you have nasal congestion or increased upper airway secretions. And for those of us that have a perfectly intact cough, we start coughing. And often you know that somebody's getting sick because of coughing. And we cough both to bring up mucus that's down in the lungs, but also to protect the airway and prevent secretions that are in the upper airway from getting into the lower airways. The other thing to consider is that when you're fighting off an acute illness, you're shunting nutrition, you're shunting energy that would otherwise be going to regular body functions, and so that can lead to fatigue. And with a neuromuscular condition, you're prone to muscle fatigue. So recognizing fatigue is exceptionally important. And then obviously with fever, your insensible water losses can increase, and it's important with that to recognize that, and with whatever therapy you're doing, make sure that you're able to maintain hydration and nutrition, as you certainly don't want a situation where you have weakness and then additional weakness because of an acute illness, and then have undernutrition or not having enough blood volume to meet your needs. So some of the challenges that aren't unique to RYR1, but we certainly see with coughing is taking a deep breath in and then breathing out as hard as you can. Come on up to the front, don't be bashful. So to cough, you need to breathe in deeply, that's your diaphragm, and then breathe out forcefully, that's your abdominal muscles. And if you have weakness in either of those, that can lead to cough weakness. And then as you get fatigued, then your ability to do things in an organized way can be limited. One of the things that I worry about during an acute illness is if a patient has reasonably good swallowing and can manage, typical saliva and nasal secretion production, if when they get sick, they become fatigued, what can happen is swallowing can become a problem, and then you can be at risk of aspirating either oral intake or oronasal secretions, which can take something that starts up here and cause it to progress into the lungs. And so recognizing that potential and having an action plan, which we'll talk about a little later, I think is very, very important. And then one of the other things that I feel is very important is if, when well, there's no need for additional support, cough assist or any type of ventilatory support that does not project, obviously, to what happens when you're sick. And so if you say, well, my son's not on the cough assist, has never used it before, if you end up acutely ill and in the emergency room or in the hospital, that's very likely to change. And recognizing that and being open to that, I think, is very, very important. So I want to move on to talk about the timing of interventions. And I'd like to focus some on secretion management. And so I look at secretion management as two things. It's airway clearance, which is actually getting stuff out, and then making mucus easier to clear. And I want to spend some time on this because I think they can be conflated. As an example, the only way that you can actually get mucus out of the body is coughing, if you're able to cough, suctioning, if you can access it in the upper airway, or mechanical insufflation, exsufflation, or cough assist. Nothing else gets mucus out, period. There are additional devices that can help make mucus easier to clear. There are a number of medicines that you can take by nebulizer, starting with saline, going to high concentrations of saline. There's something called the vest, which is developed for cystic fibrosis, which sort of shakes the chest, and that can make mucus less viscous and easier to clear, but it doesn't get the mucus out. With our CF patients, when they use the vest, they use it for about 10 minutes, and then they do huff breathing or coughing to get the mucus out, but they're able to do that. If you can't do a cough on your own and use the vest or an additional device like IPV, you need to follow that up with a cough assist, or else all you're doing is sort of moving things around in the chest. So we'll get back to some of these techniques a little bit later in the talk. So I like to think of airway clearance in terms of what you're trying to clear and where. And so certainly many acute illnesses start with the nose. So if you can blow your nose, great. If not, suctioning the nose can be very, very helpful. And then with the lower airways, if you have secretions in the back of the throat or in the upper part of the trachea. You can sometimes get that with oral suctioning. But beyond that, clearing requires an attacked cough, and for a patient with neuromuscular disease would require a cough assist or a similar device. So mucus mobilization, to me, is making mucus easier to clear, and that can be a very effective partner to airway clearance. And so what I mean by that is if you think of the last time you had a bronchitis and you slept all night, whatever the 6, 8, 10 hours that you get to sleep, or maybe significantly less than that, you get up, you hop in the shower, and you take your 5-minute shower, and during that time you're breathing humid air, and then you cough a few times, and then you get a very satisfying cough and bring up the mucus that was, probably sitting in your trachea. That was done because of mucus mobilization from the humid air that you were breathing. And we can do the same thing using different concentrations of saline, and there are other medicines such as Pulmozyme and Mucomyst that were developed in cystic fibrosis to try and break up mucus that has cellular contents in it. So there are a number of things that can be done. There is some question as to using, there is some mention of using albuterol for improving muscle function. Some people feel, at least in sort of the lab, albuterol can help improve ciliary beat frequency and help to make mucus migrate upward. I don't typically use it for that reason, but there is some potential benefit of using albuterol just for facilitating airway clearance. And so if you have trouble with coughing, it's not equivalent to having trouble with mucus mobilization. And so treating poor coughing is different than treating poor mucus mobilization. And that does not mean that if you have poor coughing that you shouldn't or can't use medicines for making mucus easier to mobilize. It just means that you need to follow that up with something that produces a good cough and an effective removing of the secretions that you've been making easier to mobilize. So I want to talk some about how to support the patient. One of the things that should be standard fare for anybody is understanding how to do chest physiotherapy and postural drainage. That, again, is within the realm of mucus mobilization. That will help to move the mucus around and free the mucus from the airway walls. You then need to follow that up with a cough. But you can move your child around in different positions. That's the postural part of it. And if you think of, we're in Pittsburgh, so we can talk about Heinz ketchup, that type of thing. And if you think of doing that on your child and you think of the airway, the airways up here, you can stand up and do percussion. But if you want to try and clear the airways that are pointing downward, you have to have the child in a head down position. And so that is also very important. There are 2 other devices I mentioned, the vest, high frequency chest wall oscillation. It's been shown to be very effective in cystic fibrosis. It's every bit as effective as doing high quality chest physiotherapy. But again, you need to follow it up with something to do a cough. And then there's a device called intrapulmonary percussive ventilation, which is nebulization under pressure with oscillation. And what that does is that helps to shake the airways. And because you're nebulizing something, that can help to make the mucus thinner and easier to clear. Neither the vest or IPV is necessary in patients with neuromuscular disease for chronic management. I never use it. I think acutely it can be very helpful. There have been selected circumstances where a family wants something else because of an acute illness and seeing success in the hospital with one of these devices, but the problem is that there's absolutely no evidence that they add anything to care chronically. And it's also additional time. The vest takes about 20 minutes. We usually do it twice a day. So you're talking about finding another 40 minutes in your day to do something that may not add anything on a day-to-day basis. One of the things that we sometimes will talk about is during acute illnesses, if it's something that we feel really is important and adds on substantially to care, that's where you get into a bit of a gray zone. But the problem is you're still have to, mount a pretty strong battle with a payer unless your payer has an open wallet and is willing to, provide equipment. Then it may not be much of an issue. But we've had lots of struggles in trying to get both the vest or IPV for patients in the home setting. So coughing more, obviously that conceptually isn't all that helpful, but using the cough assist is important. Sometimes if you have a reasonable cough and can with a bit more effort, cough more deeply, that can be useful. And ways of doing that would include doing cough stimulation with nebulization, hypertonic saline, 3% saline, or even normal saline can help with that. And then there are other things that you can do to the mucus. So if you have purulent secretions, meaning secretions with white blood cells, like during a bronchitis or a pneumonia, that's where pulmozyme or Dornase alpha can be helpful. And that's why it can be helpful in the acute setting. If you have a pneumonia and the secretions are very thick, the pulmozyme, which is done by nebulization, can help to break up the DNA, the nuclear material from the white blood cells that go to fight off the infection. And so it's perfectly reasonable to use in the hospital. It's not necessary to use outside of the hospital unless you have recurrent bronchopneumonias, which is what happens with cystic fibrosis. So if you have an experience, a positive one, of using it in the hospital during an acute illness, it also would be very challenging and probably not really necessary to have as an outpatient. Other things that you can use are just regular normal saline, just to humidify the secretions and make them easier to clear. Then 3% saline, which has sort of been the standard hypertonic saline, or 7%, which is what we use in cystic fibrosis, can be very helpful. The important thing is that the way that saline works to make mucus easier to clear is to increase the volume by hydrating it. So it's a simple osmosis. You put salt into mucus, that pulls water into it, the mucus swells and becomes higher in volume. And what that means is that you're making more mucus to clear. And it's not just going in and breaking up the mucus, it's making it thinner, decreasing the concentration, and that's done by pulling water into it. So I say this because if you do hypertonic saline, then you're going to have to do more airway clearance, because you're making the mucus easier to clear by making it thinner, okay? And we'll get back to that in acute care in a moment. And then Mucomist is something that it's N-acetylcysteine. It has some antioxidant properties, but it also can break bonds between mucin molecules to make the mucus easier to clear. It has a fairly off-putting aroma. We used to use it quite a bit in cystic fibrosis until pulmozyme became more popular. But it is out there, and it is something that's perfectly reasonable to consider if you have thick mucus that you need to feel very strongly about trying to make thinner and easier to clear. Let me pause here and see if anybody has questions. Yes?
So the pulmozyme is only good for in the hospital setting, not at home?
You can use it anywhere. The question is whether you can get it. It's only approved for cystic fibrosis. If you have something called bronchiectasis, which is airway scarring, then sometimes you can get it. The issue is if you don't have lung disease and you don't have purulent, thick secretions chronically, then there's absolutely no need for it, and it'll be virtually impossible to get. But if in the acute setting you have a pneumonia, that you have purulent secretions, it can be very helpful. But what we sometimes have to counsel parents to understand is that while it may have helped get your child better, it's not going to help keep them well at home, unlike in cystic fibrosis.
I have a follow-up question.
Yeah.
Our son has central core disease, and we use the triumvirate of versus combined with cough assist?
So your cough assist has a vibratory component to it. I don't know enough to say that that's equal. I think it's a nice add-on. I don't think it hurts by any stretch. I don't think it's quite the same as doing IPV. Are you talking about the Voxin or? Yeah.
We're trying to make an argument for IPV
Yeah.
because we've
Yeah.
heard other instances where, where that
Yeah.
is, and our pulmonologists argues against that because it's not as effective. So that's,
I don't know that the Voxin is a device that has a cough assist to it. It has ventilation. You can do supplemental oxygen and intrapulmonary percussive ventilation all in one box. And I have nothing to say that it's not a perfectly effective device. We're losing one of the big ventilators, the Trilogy, and so there's a need to look at other devices, and I think the Voxin is a reasonable option. I'm just not entirely confident in all of the sort of modules that it has inside. That's to say, it's not to say it's not reasonable to try. I don't have any lab-based evidence to say that it's equal to or not equal to. I just have my own personal concern. Well, actually, you're up.
Do you recommend doing the vest in addition to cough assist if someone is unable to clear secretions, or is that too much?
I don't feel that the vest really has use chronically.
But if they're sick, you do the vest and cough assist?
Or chest percussion. Yeah.
And when you say child in that head down position, this is very technical. But
Sure.
what do you mean? Because obviously we're dealing with really floppy kids.
Yeah.
So
A pillow or a wedge or something like that. Like literally in the hospital, they'll turn the bed so that the head is down about 30 degrees.
head down.
Yeah.
Because I think a lot of times nurses think we should have them kind of leaning up to drain down, but you're saying it should be.
Well, it depends on what you're trying to drain.
Yeah.
If you're trying to drain these airways, then you have to be head down. But to be very clear, I'm by no means advocating keeping a child head down for an extended period of time. That's going to cause other problems. And obviously, if your child has significant reflux and you've just fed them, you probably don't want to do chest PT at that point, and certainly want to minimize the head down time.
Right. But just if they're sick.
Yes.
So when you talk about kind of breaking down the mucus, like we know when our son Jackson gets sick, it always starts upper,
Mm-hmm.
and then eventually it gets down to his lungs, and we're using the cough assist.
Yeah.
When it's all down there. If we're using like saline nasal sprays or
Mhm.
other things while it's still up here,
Mhm.
then when it does drain down and get to that point, which it always does, will that kind of start the process of breaking it down if we're consistently like doing nasal spray from above, or does it really need to come through like the inhale, like?
Well, you'll make if you're doing nasal spray, you'll make the secretions up here thinner and easier to clear by the same mechanism as nebulization of saline, hypertonic saline. But it's not going to sort of pre-treat or foreshadow having how the secretions will be further down.
Okay, I guess I'm just thinking in terms of prior to using the cough assist with him, if he's been getting like the saline nose spray, is it gonna kind of help things be broken up a
The
little bit?
earlier you can start additional treatment, the better things will be.
Okay.
So whatever that is, yes, it's good. And I would certainly continue. Is there another question? Yes.
Can you talk to me a little bit about what I should be seeing after using the cough assist? And the reason I ask,
Yep.
I'm having a hard, we have one
Mhm.
at home. I'm having a hard time finding somebody in our area that is knowledgeable.
Mhm.
And so like if we go to the hospital, we take ours because they
Yeah.
won't use it. So we had an incident with his last inpatient, it was actually right before his inpatient, where, I mean, he went white and his O2 dropped lower than it should have.
Mhm.
And I had an RT tell me, well, yeah, that's what you expect with the cough assist because it's pulling the air out of him. And I just want to know, I'm wondering if my parameters are in the wrong place. Like, what should I see?
So first thing I would just want to say is that the cough assist will only bring up mucus if there's mucus to bring up. So if you say, it's not working, nothing's coming up, well, first ask the question, is there something to bring up? So on routine therapy, if your child is perfectly well and you're doing the cough assist, maybe you're bringing up sort of the normal volume, very small volume of mucus that we produce and traps stuff that you breathe in. That may be such a small volume that your child might and swallow, and then it's gone. And you may not actually have stuff coming out. The challenge is balancing both the breath in to inflate the lungs, and I can have this up as we talk about that. So, and then the exsufflation pressure. And has anybody here actually tried the cough assist? Just for fun? Good, okay. Well, I'm sure you can appreciate the discomfort in having sort of the upper airway sucked in. And so part of it is balancing what's effective, but with what's tolerated. Because if we say, use these pressures and you try and your child is screaming bloody murder and absolutely refuses, then it's not going to be a very useful treatment. And so sometimes we'll start with what you might consider subtherapeutic pressures, and then step up to pressures that might do better. The other thing to keep in mind is that, if you blow up a balloon, you can take a big deep breath and blow really hard and it pops right up. Or you can breathe in more slowly and still get to a full balloon. And so the reason I say that is that you don't necessarily need super high pressures, especially for young kids that have chest walls that are mobile. And I say this because if you do, you look at the medical literature, the person that really sort of restored the cough assist to standard use is a guy named John Bach. He's a physiatrist from northern New Jersey, an absolute pioneer in the care of patients with neuromuscular disease. The only problem is that he's very certain about his own approach as being the only way, and if you don't do it, you're an idiot. He said that to parents that have gone to him and other physicians. But that aside, his primary focus is taking care of adults. And he says you cannot go below 40 centimeters of water of insufflation, breathing in pressure, or breathing out pressure, or else it's not effective. And that's complete nonsense. All you need is to fill the lungs, and with a good respiratory therapist, they can apply the cough assist and step up and see sort of qualitatively this child's taking a deep breath. That's going to fill the lungs, get air behind secretions, and then the negative pressure for exsufflation will help to pull the air out. And then you have to balance comfort with that also. And some will say, oh, well, you need a higher insufflation pressure and a lower exsufflation pressure, or opposite. It's really what is best for the child. So to get back to your question, it is ideal, but not absolutely necessary to have somebody that is exceptionally experienced in doing the cough assist. Some of it can come from starting with pressures that just allow your child to accommodate to using it, and for you guys as the primary caregivers to learn how to administer it well. And then once you are sort of into a routine, then you can work on adjusting the pressures up if needed. There's another hand that went up.
We've had issues in hospital where the respiratory therapist that comes in doesn't know how to administer the cough assist or just does it correctly. And so
Yeah.
we're very proactive about doing it ourselves with them, which I think makes a really big difference because you just don't get somebody that's super knowledgeable.
Well, it has to be somebody that's not looking away and just turning the dial back and forth. The other thing is that you need to apply the air for at least 2 seconds. It's about a second to get up to pressure, and then another second where you're at pressure, where the air can sort of get around through collateral ventilation behind where the secretions are. If you're just back and forth really quick to get through the treatment, it's going to be largely ineffective.
So if his O2 is dropping,
Yeah.
significantly,
Yep.
that probably is the wrong.
No, I would actually argue that that's good. Not,
Okay.
yeah, just bear with me here a little bit. So if you have secretions that are down here, and this part of the lung is filled with mucus, or an airway is, no blood's going there because blood shunts away from where there's where there isn't oxygen. For obvious reasons, you want to get oxygenated and then go take the oxygen to the body. If during a cough assist treatment you mobilize that mucus and then it comes up, then it goes down, you don't get it all the way out, and it goes down to another part of the lung, you're going to desaturate acutely. The mucus will block the airway, you'll have blood going back there, no air coming in, no oxygen, desaturation. The solution should be taking a pause, if you want to, give some oxygen, let the oxygen recover, and then continue on. Doesn't mean immediately, but the thing that shouldn't happen is say, well, he desaturated, we can't do the cough assist. That's the absolute wrong approach. The approach should be pause, rest, and then continue. Now, that tells you that you're mobilizing mucus and you're making progress, you just haven't completed the deal.
I would say in my experience of doing this for many years that it was uncomfortable, but then I did learn that when I saw that, that meant Gabby had moved something and I needed to persist.
Yep.
That we were almost over it. Like
Yeah,
we just
yeah.
needed to persist.
Absolutely. As you'll get a sense of comfort, but certainly pausing for a moment. And what will eventually happen is that where the mucus is now, the blood will get shunted somewhere else, and the oxygen level will recover. That doesn't mean that your job is done. It means the mucus is still there. It's just somewhere else, and so you still should go back in and try and get it. We jumped ahead a little bit, which is perfectly fine, but when we talk about airway clearance, I like to talk first about what we do when we cough, and it involves 3 distinct phases, 2 of which we can manage. The first is a big deep breath in, which we can do with the cough assist, forceful exhalation, which we can do, and then for about a quarter of a second, the glottis closes. We do that completely automatically. And what happens is that you're building up pressure in the lungs against a closed glottis, glottis being vocal cords. You open your vocal cords, the air comes up explosively through the respiratory tract, ideally bringing secretions. The cough assist can administer pressures that are about a quarter of what you can get, or less, actually significantly less than what we get from doing a cough for somebody that has intact muscles. But it still can be exceptionally effective. So to compensate for a weak cough, we can either do breathing in, insufflation, and helping with exsufflation, and then doing both together. In France, the standard approach is using a device like this, which is called the Alpha 2000, and it's a device to do what we call intermittent positive pressure breaths. It's just a breath in, and then you release it, and then a breath in, and then you release it. So it's helping a patient breathe in deeply, and then the breathing out is whatever residual muscle, expiratory muscle strength they have, and then the recoil of the respiratory system. So if you take a big deep breath in, you're stretching your rib cage, and the rib cage will settle back down to resting volume, and that helps with exhalation. We don't typically do IPPB, at least not anymore, because we have the cough assist and similar devices that do both insufflation and exsufflation. You can also do breath stacking, and I'll show you the device in the next slide, which is just a series of breaths at tidal volume up until your lungs are full. That takes some training, but it can be very effective, and especially if you don't have access to the cough assist or don't have access to power. And then there's something called glossopharyngeal breathing, which is using the throat muscles to sort of push air into the lungs. And John Bach uses this quite a bit and swears by it, and I've had conversations with him, and he says if you can actually teach a patient how to do it effectively, it can be very, very helpful, both for airway clearance and actually for breathing in more deeply. But it takes a lot of training, and I've not had any opportunity or haven't used it in 30 years. The device over on the left, this is a one-way valve for doing breath stacking. The air will come in over here. I guess I should use the pointer. The air comes in right here through a one-way valve into the patient. They breathe in, and then they, instead of breathing out, well, when they try and breathe out, there's a one-way valve that's set at a high pressure so that they can hold their breath. And what they will do is breathe in a series of just regular tidal breaths in until their lungs are full, and then the mask will be removed and they can breathe out or cough. So it's a way of recruiting lung volume. The device in the middle, you all know, that's the cough assist, and you can set that to do just insufflation if you want. And we do that some for lung volume recruitment, for deep breathing to help expand the lungs, and that can be a helpful way of preserving lung capacity. And then, of course, the Alpha 2000 is over to the right. You can also do a manually assisted cough, and this is an example of that. So the two top images are inspiratory. The left images are doing just focusing on assisting the chest. The images on the right are assisting the chest and abdomen. And so what you can see here is on inspiration, the therapist relaxes, and then on exhalation, they either compress the chest or compress the abdomen and chest together. And that can be an effective way of doing airway clearance in conjunction with breath stacking if you don't have equipment or unable to get it. So you can do breath stacking or a manually assisted cough together. The mechanical inexsufflator or cough assist is another approach. Excuse me, get rid of that. And so, as you may know, the cough assist has about 5 more years of existence, and it will be taken off the market. There are no new cough assists being produced. The company Hillrom, or Respiratory Hillrom, they had some issues with the FDA with the Trilogy, as you may recall, from a number of years ago. And the FDA has sort of dropped the hammer on them, and I think they've decided that in the US it's not worth the effort. So the cough assist will be going away. These two other devices down here, the Sinclair and the Byways, are very, very effective and perfectly reasonable replacements for the cough assist. So one of the things the FDA made sure of is that Hillrom and Respironics will be, for the 7 years, which is now 5 years, fully maintain any existing cough assist devices. So if you're using a cough assist and you like it, you can use it. Certainly through the next 5 years, nobody's going to make you give it away, but if it breaks after that time, you can transition to one of the other devices, and they should be perfectly fine. The way that we do things typically, a standard treatment is you choose an inspiratory and an expiratory pressure, and then you can actually, as I mentioned, once you get to the target pressure, which usually takes about a second, you want to hold for 1 or 2 seconds. So the insufflation and the exsufflation should be between 2 and 3 seconds. If it's shorter than that, you may not get the full benefit. As I mentioned a little bit ago, one of the advantages of doing that is that if you have mucus in an airway and you apply the pressure for a period of time, you can get air sort of percolating around through collateral ventilation to fill the lungs behind the mucus, which then makes it more likely that on exsufflation you can actually get the mucus out. So just back and forth breathing in is not effective. You need at least 2 seconds, if not 3. We usually do 5 cycles back and forth, pause, suction, spit out whatever might have come up to the throat, and then do that about 5 times. But what I tell parents is that you cough as much as you need to. That's the way we do it. And so you can often read a patient and get a sense of there's something still there. I can feel it rattling around. I've done my 25 breaths. Well, you can do as many as you need to above that. We usually recommend twice a day and maybe every 4 hours during an illness, but there are times when we might recommend every 10 minutes for an hour if there's mucus that is causing a problem. It really depends on what you feel is ideal for your patient. For nurses, unfortunately, you have to have some type of a schedule. And what we usually do is twice a day and then every hour is needed during illness. Should be very, very workable. So this is just some data next to show what you get from doing the comparative benefit of doing an unassisted cough. And this is something called peak cough flow, which some of you or some of your children may have done in the office. And it's like the name implies, you cough and you measure how forceful the flow is that you can generate. The threshold for successful airway clearance is 160 liters per minute. And so if you're below that, the feeling is that you can't generate good enough flow to remove secretions well. There's another number that's 270, which is the number below which, if you're below that number when you're well, it projects to having a flow below that 160 liter per minute threshold when you're sick. So so those numbers are what we usually use to determine whether somebody needs assistance. But here you can see this is a mixed population of patients with neuromuscular disease. I think mainly SMA and Duchenne. Unassisted cough, the mean value is well below the 160 liter per minute threshold. By doing exsufflation or expiratory assistance with a manually assisted cough, you have a rise in flow above that 160 threshold. And then if you do cough after breath stacking, and help with inspiration, you have a similar rise. If you do both together, you have a further rise, indicating that the ideal approach really is helping with breathing in more deeply and breathing out more deeply. And so I want to spend a little bit of time talking about mucus mobilization. So this is the vest. This is a perfectly reasonable way of mobilizing mucus. The question really is, when do you need it? I personally feel that in most patients with neuromuscular disease, there's no real indication for using it chronically, unless you've had lots of problems with pneumonias and have lower airway lung disease. But the challenge, of course, is getting it approved, which can be very, very difficult in patients who don't have cystic fibrosis or don't have significant lower airway disease. This is IPV. This is the version that's available for home use. Effectively, what it is that device is a pressure generator that can create oscillations. And so you apply pressure. It helps to keep the lungs, the airways open. Then there's vibration that helps to sort of shake the airway and shear mucus off the airways. And then you can nebulize some type of substance. We usually do saline. You can do hypertonic saline also. And then let me just pause and see if anybody has questions before we talk about ventilation. Yes?
I have a question. Effectiveness of the IPV versus the vest. And from what I can tell, I believe our caucuses does not have the IVP, sorry. I may have said that wrong. And then if it matters to your answer, trach versus non-trach, if that bifurcates your answer.
I'm sorry, what was the last part?
Just if there's effectiveness of maybe a trach versus non-trach. In our instance, our daughter has a trach.
Yeah.
I didn't know if there was
All of this, you can do IPV, cough assist through a trach without question. In terms of the vest versus IPV, they're effectively identical in what they do. I would tend to lean more towards IPV because you can administer nebulized medication. So there's nothing that says that one is definitely better than the other.
If you're weak.
Yeah.
And you can't make a seal on that mouthpiece, does that IPV work through a mask?
Oh yeah, absolutely. Yeah. Yeah, you can do it that way also. So let's briefly talk about mechanical ventilation. So during an illness, if you have mechanical ventilation and are using, say, nighttime BiPAP, it may be reasonable to consider switching over to using it during the day also to help with rest and fatigue, managing fatigue. The other thing that you can get if you have chronic mechanical ventilation is you can increase the pressures to help keep the lungs open better. You can increase the lower pressure or transition back to using if you're using it just intermittently, transitioning back to using it all the time. And that distending pressure can help recruit lung and help to mobilize secretions better. And then the other thing that I feel very strongly about is if you're in the hospital and you're on ventilation, invasive or non-invasive, the weaning process shouldn't really start until you're off of supplemental oxygen, if you're off oxygen chronically, which most patients are. And so the reason I say that is that if you're requiring supplemental oxygen, it means that you have mucus in your airways and you're having a mismatch between the air going in and the blood going through the lungs. And so if you're doing aggressive weaning of ventilation and are continuing with oxygen, what you're doing is you're not doing the full job of clearing secretions before decreasing respiratory support. And so that's one thing that I think is very, very important. Just briefly, there are two components of ventilation. One, which I think is the most important by far, is the interface. Finding something that's comfortable, that fits well on the face, ideally on the nose, but there are oral devices that I'll show you in a moment for mouthpiece ventilation during the day. In certain circumstances, you can use a mask over the mouth and nose. We like to avoid that just because it removes the ability to vocalize, and there's a potential risk of aspiration if you vomit. But in the rare circumstances we've done this in the last 30 years, I've not had anybody that has had that happen. It's really more of a potential risk. And if you have nursing, then it really becomes no risk or very, very, very mild risk. Then, of course, tracheostomy, and then there is sort of partial or full body external ventilation, negative pressure ventilation using a cuirass, which we don't use very often. Most of the ventilation is pressure ventilation, non-invasively. If you have a tracheostomy tube, we can ventilate by applying a certain volume or a pressure. So this is sort of a wide array of, this is actually an old slide of some different types of nasal masks, just to point out that it's important to find one that fits. A lot of these that have silicone around them can be molded to the contour of the nose and the maxilla over the face. A lot of the ones over to the right have a silicone baffle that is made to sort of pop open or inflate with air to, in theory, provide an air cushion to make the mask sit comfortably on the face. And so if you really cinch the straps down on the mask, that air baffle goes away. So that's part of the fine-tuning of putting a mask on. The most important challenge is finding a mask that fits for small children. These two devices on the bottom, the SleepNet IQ and the device over to the right, I think it's called the Simplicity, were ones that we used fairly widely. Now we do have devices that are made specifically for children, which we've had for probably 7 or 8 years, and that's been a nice addition. So you can also have cannula devices that go under the nose, which can be nice in that you don't have a big bulky thing sort of sitting between your eyes. This is a device that has a chin strap that helps to keep the mouth closed at night, which can be a problem. Do I have to separate you two? No. Okay. And then this is a oronasal mask, and then the device over to the right came out soon after the Avatar movie came out, and I thought it sort of looked like an Avatar mask. There's no connection that I'm aware of, but I looked at it the first time I saw it and said, who on earth would ever want to use that? But we actually use this quite a bit in our smaller children in the hospital. So here's another device another version of a chin strap over to the right. And then this is mouthpiece ventilation. So behind that wheelchair is an LTV ventilator. You can use any non-invasive ventilator that's made for chronic continuous use. This is an articulating arm that connects to the circuit, and then you can place the circuit right by the mouth so that the patient just has to sort of turn his or her head to the side, put the lips around the circuit, and then start breathing, and then it will give a breath. This is a perfectly reasonable and effective way of doing breathing during the day. The other, and you can actually mount the mouthpiece anywhere. It doesn't have to be in a wheelchair. You can mount it to a desk, a chair, wherever you have a firm mounting area. And then these are different types of tracheostomy tubes. I look at a tracheostomy tube as a quality of life decision. I don't think that tracheostomy tubes are wrong. They can be very helpful in that it removes everything up here to on the neck. And one of the things that helped me sort of see things differently when I was younger and less sophisticated, I felt a tracheostomy tube is a sign of failure and you should avoid it at all costs. And I had one family that their son had SMA and had come in the hospital about 3 or 4 times during a winter with about a couple weeks on ventilation invasively, and then extubated to BiPAP, and then another 2 weeks of weaning to being off for 4 hours a day. And this is the 3rd time we had been through this, and then the father looked at me and said, "I just want to see my son's face. I don't want this anymore." And so, he transitioned to using a tracheostomy tube, and the family was quite happy. So it requires more training, but to a certain extent, some of the work is easier than maintaining an upper airway, maintaining an airway non-invasively. Yes?
Our daughter has a trach and she doesn't require a lot of pressure support,
Mhm.
which is healthy. It's uncuffed, but when she's sick, I feel like our doctor always pushes us towards the cuffed trach,
Mhm.
which our daughter hates. But
Yeah.
do you think that really makes a difference
It-
while you're sick?
It can, and what you'd be doing by doing that is more directly transmitting the pressure from the ventilator into your daughter. Sometimes we have patients who will inflate the trach at night because things relax and the leak becomes too much and they don't ventilate well. Yes?
I'm a pediatric neuromuscular provider. I was wondering if you could speak to trach removal. So I had a patient with R1
Yeah.
central nuclear myopathy who was able to successfully have his trach removed.
Yeah.
But there was controversy because obviously in other conditions that doesn't generally happen. If you could speak to maybe that population.
Yeah, and especially today with many disease-modifying therapies available and a completely different prognosis, I don't think of a trach as being permanent if needed. If it's done during the midst of a really bad pneumonia, it could be very, very useful in allowing you to move forward with stable ventilation during rehab and then working on weaning. So I've decannulated a couple of patients. We have had more experience with this with SMA, with the disease-modifying therapies that have been introduced. I don't see that a trach needs to be something that is permanent if the patient progresses to the point where they don't need to be on continuous ventilation and can be transitioned to a nasal interface. Yes?
What did you see when you took them off the trach? What told you they were ready to come off?
Well, the process would be you're on 24 hours of ventilation. And doing 24 hours of ventilation non-invasively can be very difficult. You can, in an older person, you can do that with mouthpiece ventilation and then nasal ventilation. So what I saw was that we were able to wean ventilation during the day and get the patient off of ventilation during the day, and then be able to transition to just nighttime ventilation. And that can be done perfectly well through a nasal interface. And so that would be the thing. You'd want to have not be on continuous ventilation, and then, have ventilator pressures that you can comfortably do non-invasively.
What did you see for heart rate in the child, like let's say a 2-year-old? My son has a trach.
Yeah.
He's had it ever since he came home from the NICU.
Mm-hmm.
We tried weaning him off
Mm-hmm.
a couple of times in the first 5 months while he was there.
Yeah.
And he ended up coding.
Yeah.
His CO2 levels just got really high.
Yeah.
And so that freaks us out a little bit.
Yeah.
We
I
get
can
up to
understand.
About 70 minutes
Mhm.
off the vent, and he just essentially gets tired and goes to sleep, and we just put him back on the vent. So
Yeah.
it's hard to get past that point. And
Yeah.
we've been told that like if his heart rate goes above 150-ish consistently, if it's staying above 150, put him back on the vent. His oxygen doesn't drop.
Yeah.
His oxygen remains great, 99 or 100 or 98. I mean, it's beautiful. But
So.
it's just kind of where we're at.
Yeah, no, I completely understand, and that's a fairly strong message that your son still needs to be on ventilation. And what we'll usually do is I'll start by saying, what happens when you take your child out of bed and, get them dressed and disconnect from ventilation? Is it a rush to reconnect?
No.
Or, no, I'm just saying hypothetically, if you get over that threshold, then we are in the realm of coming up with a slow weaning plan. Maybe trying, it can be either going all the way to just being on CPAP or off for a brief period of time, or just sort of slowly stepping down. And the slow stepping down in the size of the breath requires the child to do more of the work. So if the ventilator's doing 100% of the work, and then drop the high pressure, the higher pressure a little bit, and have the ventilator do 90% of the work, and the child's doing 10%. That may be that's one approach that allows the child to sort of build up their own strength, and then you sort of slowly wean down to being on just CPAP, a distending pressure.
Would you be checking the blood for the CO2 levels intermittently during that time?
Well, sort of. We would typically have a capnograph, an end-tidal CO2 monitor at home.
But we had that, and that
Yeah.
didn't catch it.
Yeah.
They had to do the blood test, is what they, and that wasn't until after he coded,
And
they found his levels.
one of the reason,
Was like way up.
yeah. Well, the one challenge with the end-tidal CO2 is making sure that you're getting an accurate reading, because if you're not getting a true measure of the alveolar CO2, and you're pulling in air from outside when you're doing the CO2 measurement, you're going to get a falsely low value.
Thank you.
Sure.
Yeah, this is
Yes.
always my fear with the end title thing, because I check the end title for like 15 seconds,
Mhm.
and they're like, that's 35, and they leave. And they're like, was that enough time to measure something like that? Like, how do you know you're getting an accurate read of an end title if it's not like the blood
Mhm.
test?
Yeah, well, on many of the end-tidal monitors, you can see the flow wave of CO2. And if you're getting a plateau, you know that you're getting a maximal value that the patient has. One way around that is just to keep it on for a period of time.
Yeah.
But you have to make sure that you don't have a leak, and that the air that is going through and being measured is only coming from the patient. So we're over time. I apologize. I'll be around until the end of the day. I'd be happy to talk to any of you if you have further questions.